Well, thanks for that introduction and welcome everybody. I hope that you attended webinars 1 and 2. And again, there's so many different keys to successful clear aligner service, but this is very, very important. So we've already approved the case, and now we are going to deliver aligners to the patient, and we're going to talk about what's really important and what separates supervised digital orthodontics and clear aligners from, say, direct to consumer. And there's a significant difference when we talk about attachments and interproximal reduction. Just quick on my background, I've been doing this for a very, very long time, since the beginning of clear aligners being delivered to patients back in 1999, so a long, long time ago. Basically, it says I'm old, maybe a pioneer. I've done this quite a bit. I've utilized multiple different types of clear aligners, and we also deliver multiple types of clear aligners at our residency program. So very, very happy that we're able to educate more and more dentists on that. And it gives me a unique perspective, because I really believe that clear aligners are very, very similar now to 30 years ago when I practiced with no clear aligners and we could only deliver braces. And we talked about the differences with the brackets. And now we're starting to talk about the differences in clear aligners. But there's more similarities than you might think. And there's also similarities between using clear aligners to move teeth and using fixed appliances to move teeth. We used to live 25 years ago, we lived in a parallel universe where if we were going to use clear aligners, we did one thing. And if we were going to use braces, fixed appliances, we did another thing. So let's dig right into it. And I think we actually want to talk about our objectives tonight. So the first thing is we want to delivering the aligner to the patient, how to educate them and teach them about utilizing this removable appliance, very, very different than braces. But again, we're going to educate them just like we do for fixed appliance patients. And then just like we bond brackets, we're going to bond attachments, which help optimize the tooth movement. And then sometimes we are going to perform IPR, similar to when we might perform IPR for fixed appliances. That is sometimes a unique concept for people, because people associate IPR more recently with clear aligners. And then finally, if we've done those things there, and again, we've done our treatment plan really well, then we're just monitoring the patient for success and determining whether we need to do additional aligners like a refinement, or whether we're just heading them into their retention protocol. So again, early on, we've talked about case selection. Proper case selection leads to success. And then really understanding, I'm a firm believer in this. I teach my residents this. We spend a lot of time on virtual treatment planning. This is unique to clear aligners, but it's come full circle. The artificial intelligence has advanced so much that it is now being utilized by fixed appliances because of the advent of 3D printing brackets. So all of this transformation, this digital revolution, the transformation of orthodontics has been led by these clear aligner companies and all the technology. So again, super important case selection, super important virtual treatment planning, and that's computer-aided design. And then, of course, once the case is approved, we go to computer-aided manufacturing. The company prepares all of the aligners, boxes them up, sends them to your office. Now, what do you do? And again, it's very similar to the bonding appointment with braces. The patient's going to be in the office, and we're getting ready to deliver orthodontics. And so we're going to have start videos, educational videos on how to take care of those appliances, how to wear them, how to clean them, so forth. And then we may put some attachments on, we may do some IPR, and we're going to talk about that as well. So in the start kit, we're going to talk about how to store the aligners, how to take care and protect the aligners. We're going to talk about inserting the aligners and how to remove the aligners. And then, of course, how to clean them. And then, oh, by the way, how to clean your teeth and floss and so forth. And again, huge difference between fixed appliances, because obviously it's a removable appliance. It should be relatively easy to take care of your dental hygiene. There's going to be written information, because we can do all the oral information. We can have videos for them. But again, they need references later on. You know, we give them 10 minutes of information. Well, what do they really retain? So it's great to give them written information, just like we would with braces. And again, digital age, we can now have these QR codes that they can go to videos, these apps, and they can get all the information they need when they're at home and the office isn't there to answer those questions. So here's an example of a start video.
Each day, you must wear your aligners for at least 22 hours. That's while sleeping and for most of the day. Remove them only for meals or to brush your teeth. This is very important. If you leave them out for more than 2 hours per day, your teeth will not be ready for the next aligner stage. That could lengthen your total treatment time. Remember, only remove your aligners to brush, eat, or drink beverages. The exception is water, since it won't stain aligners or grow bacteria.
Was a really well done video. And other companies have very, very similar videos as well. Invisalign for one, Straumann ClearCorrect, they all have these videos and educational materials as well. Okay, so we've educated the patient. Maybe they've tried on their aligner in the office, and sometimes we may place attachments. Some cases you don't need attachments. And again, we're going to talk about that because the tendency with the artificial intelligence is that we're getting attachments placed more and more for various reasons. But what is really the placement of attachments? Again, similar to bonding a metal bracket or the ceramic bracket, the attachment is helping us to retain the aligner on the tooth. Really, when we talk about clear aligners, the nuance between that and braces is that braces, the arch wires we place, pull the tooth to the desired position, whereas clear aligners push the tooth to the desired position. And so we really need to push the teeth accurately and with the proper force, need large surface areas. And that is why large teeth typically, in my mind, do not need as many attachments because of the increased surface area already. So attachments, these translucent composite shapes, if you will, that we bond directly to the teeth, increase the retention of the aligner. They can also be optimized now because we know the direction of the force that we're applying to the tooth to push it to the desired position. And so we can actually design ideal surfaces, optimize surfaces, if you will, that oppose that force and with increased surface area, allow us to more predictably move teeth in the direction that we desire. So again, we're going to place some attachments. We'll talk more about that in terms of numbers of attachments. This is what I typically like to see. I don't like to see a lot of attachments in the anterior. But we, in a digital age, we might have our computer screen up chair, and we would tell the patient, hey, we're going to place 5 attachments today. This is one of the reasons why. It's going to increase the retention, help your teeth move more predictably, so forth and so on. If we don't have computers chair side, we're going to have the analog version, the paper version. So in this particular case, we might say, hey, we're going to place these attachments on the top teeth and the bottom teeth. And oh, by the way, yes, I'm sorry, we do have some attachments on your anterior teeth, but this is the reason why. I'm trying to extrude your upper teeth, and without those attachments, it's a less predictable movement, so forth and so on. Personally, I try to design my cases with very few attachments on the maxillary anterior teeth, or even the mandibular teeth for that matter. We're also going to talk about, we're going to show a video in a minute, placing buttons which can help the patient to wear elastics. In this particular case, this shows that we're going to place these buttons on number 19 and 30. There's going to be slits or cutouts on 6 and 11, and they're going to wear what we call class 2 elastics to help correct their bite. The reverse class 3s would be, the cutouts would be on 3 and 14, and the slits would be on 22 and 27. So it really helps us to educate the patient, and it also reminds the assistant or the doctor what is the overall plan. Attachments, it's no more in any indirect bonding procedure that you have performed, and you've probably performed a lot of indirect bonding, so we don't have to worry about that. This is the basic armamentarium. The only thing different is that we do have, because it's indirect bonding, we do have these attachment templates, and we'll show how to fill those and then also to do the bonding. But again, just like any other indirect bonding procedure is in your kit. We're not going to spend a lot of time on this. When I first started, we used to etch and use a primer that was compatible with the composite. Now they're even talking the video, I believe, with the etch and primer combination. So just make sure that the primer is compatible with your universal composite. And when we talk about that, there's two things. This brand, Grandioso, you don't have to use that brand, but the main point and strength of this is that it is a universal nano hybrid composite, and it is very, very strong, a hybrid composite. And it also has a translucent or natural shade. So you don't want to spend, especially on adult patients, you do not want to spend a lot of time trying with all your kits and try to do shade matching, especially if you have a lot of anterior attachments. Another reason I don't like to place a lot of anterior attachments. If you do have flash, you're going to clean it up with a carbide burr. And of course, let's talk about these videos, educational videos for both the patient and the assistants and doctors as well.
The attachment template comes in the same box as the rest of the aligners. So the day of the appointment, you need to remove that bag, which is labeled the attachment template. The templates have walls for the composite. In our office, the staff fill them prior, once again, to the patient's arrival. Some things to focus on is that you don't want to underfill and you don't want to overfill. If you underfill the attachment, then the attachment's not going to stay on the tooth when you actually seat the tray. And if you overfill, you will get too much flash. The flash then can flow into the contacts. And if that's the case, what you can do is you go in there with a scaler and try to get off. Or sometimes you may even need a handpiece to remove if there's too much. If we do overfill a little bit, we'll go in there with a micro brush and just clean around the edges of the well.
Really nicely done video. I really like that micro brush technique so that you don't have a lot of excess flash. And so it's very, very important. Again, a wonderful educational material. Other companies such as Invisalign, such as ClearCorrect Straumann, just to name two, also have educational videos as well. And now we're going to talk about the actual placement of the attachments.
Once I am done with the bottom set, then we go ahead and move to the top and do the same procedure all over. With the etch and primer, what I first do is I blow air on the tooth and then I go ahead and apply it. I apply it for 6 seconds, blow some air, and then apply it for a second application. The second application is just like a second or two, just to help with the bonding. You blow some air because you always have too much etch on the tooth. You don't need it swimming in that. You just need a light coat over the tooth. When you're done seating the upper and the lower tray, if you do need any buttons, this is the time to do it. The template tray will have a cutout for the button. So you go ahead and prepare that area the same way you would for an attachment. You start with the etch and primer and you prepare the tooth. You could see that I'm blowing the air. I did my first application. Now I'm doing my second application. You want to make sure that the button is not sitting or touching the gingiva, because if it is, it can cause some inflammation and just difficulty with brushing. So I went ahead and pushed it up just a little bit more occlusal. You want to make sure that the base of the button is completely loaded with the composite. It doesn't need to be that much. You just need to make sure to coat the whole base. So as you push on the tooth, it all seeps out from the edges. You want a little bit excess, which shows you that there's enough composite on the base of the button. And then you go ahead, as you're putting it on the tooth, you do a little push just to help get that excess to come out. Then you go ahead with a scaler around the button and remove the excess. I go ahead and light the button 3 times, just on the 3 different sides of it. When you're done putting all the attachments on and the buttons and everything's nicely cured, then you're done with the bonding. You can go ahead and remove all the isolation equipment or the triangles and the cheek retractors and the attachment template, rinse the patient out, let them swish, and you're done with the bonding procedure.
Another excellent video. And again, I would comment, we tend to place these buttons on the mesial buccal cusps, either on the upper or lower first molars. And we do that for two reasons. One, ease of placement for the operator, but also for the patient to be able to hook up their elastics. It prevents, those buttons are a little bit better than just putting cuts in the posterior, as we found that it was difficult for the patients to apply the elastics, and they would also have the aligners be displaced or come out. So the buttons hold on to it and don't apply that vertical force. So we've talked about placing attachments. Here's the only other thing. Not every case needs attachments, and be cautious, because in your virtual treatment planning, the AI, if you rely 100% on the AI now with the optimized surfaces, we're starting to see many companies produce aligner virtual treatment plans with, say, 14 attachments on 14 teeth. And here's what I will tell you. If you're putting 14 attachments on 14 teeth per arch, you should really consider fixed appliances. So that's my little 2 cents there. I have successfully moved many, many teeth without any attachments, but there is a reason to use them. And what I particularly do is I design my cases to use those attachments for difficult movements for clear aligners with the push force, such as severe rotations greater than 40 degrees, such as extrusions, true extrusions of greater than 1 millimeter. So let's switch to interproximal reduction. Now, some cases don't need interproximal reduction. Some do, and again, some people deliver their aligners, put all the attachments on, and perform all the IPR at the same visit. My patients want a non-invasive appliance. That's why they don't want fixed braces. So sometimes I will stagger my attachment placement and postpone my IPR till later in treatment, so that their initial visit, they're just trying on their aligners, learning about the aligners, and they're going to have a really nice non-invasive visit. However, with the concept of really short treatments and or long distance orthodontics, I'm not going to see them because they're cross country in college. We do have to sometimes put all the attachments on and perform the IPR and go over all of that, but that's a very long appointment. That's typically when you're like bonding upper and lower braces, and it takes an hour, hour and a half if things don't go well. Okay, so let's switch gears to interproximal reduction. And what is interproximal reduction? Well, it has nothing to do with clear aligners. It has to do with relieving crowding, maybe to avoid extractions. People don't like to extract teeth as much as they used to in the 1970s, say. And I'm talking about orthodontists as well. So as teeth are being pushed or pulled, whether it's fixed appliances or clear aligners, we're trying to resolve crowding and get rid of rotations. But sometimes the teeth have an overlap and they have this binding. And we all know that their teeth are a triangular nature, wider at the incisal edge than at the CEJ. And so there's going to be an interference as those forces are being applied to those teeth. So IPR is an auxiliary that can be utilized with either fixed appliances or clear aligners. Okay, IPR is IPR. It has nothing to do with clear aligners. So IPR is going to be used to decrease that binding. It's going to be used to reshape teeth. There's things called Bolton discrepancies. So maybe 8 and 9 have an asymmetry in terms of their mesial distal width. So I want to correct that. Or on adults, if you get rid of an overlap, again, 8 and 9, sometimes that papilla didn't develop in there as those teeth were erupting. And when you correct that crowding, you must point out the fact you're going to have to do interproximal reduction to decrease those black triangles. Again, we avoid crowding. And suppose there is no crowding, but in some malocclusions, let's say it is I need to retract lower incisors that are perfectly straight because we have an edge-to-edge bite or almost even an underbite, then I'm going to need to do some IPR that allows me to constrict the arch or retract those teeth. And we're going to talk about the 3 C's of IPR after this slide. So I love this slide. If you're a general dentist, hopefully you have an orthodontist friend that can get you this. I'm working hard to get the AAO to put this procedure out there in this brochure form. We don't really need the patients to read all that information. It's a pretty big brochure, but it's the picture paints 1,000 words here on the left. So interproximal reduction, what are they showing? Crowded mandibular teeth. How are we going to solve that? We're going to use braces. Oh, by the way, it's not just the braces that's solving the crowding. It's going to be this interproximal reduction, which is like floss with a sandpaper grit. Doesn't make your teeth more sensitive. And then look at the bottom, you have straight teeth. So I show this to every patient, fixed or removable cases that are possibly going to need interproximal reduction. I've done over 100,000 teeth. I stopped counting, and I've never had a tooth become sensitive, mainly because of what I call the 3 C's. The 3 C's are, why am I doing this IPR? I'm doing it to help relieve crowding. How do we relieve crowding? Braces or clear aligners. We have to procline teeth, expand the arches, or do some interproximal reduction. Those are the 3 ways. The 4th way, which we don't like to do a lot, is to extract teeth, and people want to avoid them. The 2nd C is what I talked about before. Suppose the teeth and the contact are pretty regular, there's no crowding. How can I retract that arch? So I'm going to have to do interproximal reduction so that it allows me to constrict the arch. That's the 2nd C. And then finally, I never do 100% of the programmed IPR, such as in this case, because if we do that, these teeth are perfectly straight. I need to retract. I need to make sure after I've done this IPR or during the treatment, perform some of that IPR. I want to retract those teeth. If I were to go in and just perform all of the IPR on those 7 contacts on day 1, I basically take it straight teeth, and now I've created a spacing case. I can close those spaces very, very predictably, but what if I don't have to perform all of that? And if I'm conservative with my IPR, then I'm still going to be able to perform it as needed. And most of the time, you don't have to do 100%. It's the difference between the virtual world and the real world. And I've had many conversations with this, arguments, but I believe I'm correct in this case. But the digital world will never be able to duplicate the PDL. And the periodontal ligament, as we know, if we're in restorative dentistry, sometimes we put a wedge in there and then we fill that contact. What happens when we remove that wedge? The PDL moves the tooth back to its original position and tightens the contact. I think we're having the same things where if you go ahead and perform 100% of the IPR, you will end up with spacing. Okay, that was the invention. This isn't the talk for that, but that is actually the true invention of virtual C-chain, because 25 years ago, we were doing 100% of the programmed IPR, and we were finding that our treatment plans didn't close 100% of those cases. So again, same thing as when we place attachments, we're going to have our virtual treatment plan up on the computer. If not, we're going to have it chair side in the analog form here. I'm telling you, I'm going to perform some IPR on the lower. What is the armamentarium? This shows 2 of the 3. I use the wheel on a slow speed for black triangles primarily. I use the strips for better access. I can pretty much do almost any contact. I primarily do IPR in the anterior region. In the posterior, if I want to get rid of any crowding or rotations, I try to do expansion if possible. And then finally, we use a high speed, which is a different type of IPR that maybe not everyone is familiar with. Again, the strips, super important. There's all different kinds, but 25 years ago, we didn't have perforated strips. So please get those. And then they can be either single-sided or double-sided diamond strips. Okay, so the 2 keys are use the perforated. It makes it a less invasive procedure. And also, I like to use single-sided. I think it's a little more accurate. Floss with a sandpaper grit. I'm going to use like my flossing techniques, wrap a little C around the distal of that particular contact, and then the mesial of the adjacent tooth. So I also use finishing strips, and again, dentistry or any kind of polish, coarse, medium, and fine. This is just an example of a single-sided perforated disc. And again, the dentist or orthodontist is going ahead and doing a little back and forth polish, just enough to where we've released the binding of that tooth. If we're going to reduce black triangles, I use a double-sided diamond disc, again, perforated. And the most important part about this is the disc guard. Again, I do this two-handed. You'll see in the technique, we don't use lip retractors, which you can do, but I don't find it's necessary. And as long as I have a wheel guard, I feel very, very comfortable that I'm protecting the soft tissues for the patient. These are sterilizable. The metal ones, obviously, there are now plastic disposable ones as well, but please use that guard. It really will make it, again, a less invasive procedure. So again, if I have a fairly straight contact, I'm doing it for a black triangle here that you see on the right. I'm going to go through both double-sided, so I'm getting the mesial of both of those teeth, and we'll be able to reduce that black triangle when the aligners constrict those two teeth together. IPR strips, obviously very, very flexible. I can get through just about any contact. There's a little shim in between the two sides, and rarely do I ever have any problems getting that shim through. It's a very, very thin piece of metal. Now, do you want to introduce a new concept to a lot of people? It's general dentists are better than orthodontists at using this technique. But I have found it's probably the least invasive, and I feel as though I can really do this immediately, because sometimes with the wheel, you need really kind of to round trip the teeth, so to speak, get rid of some of the crowding, give you easier access. This I can do on day one in terms of adjusting the teeth. And so if we look on the right, there's the interferences as we're going to rotate those teeth or decrowd those teeth. There's going to be those bindings in the areas where those black dots are, if you will. And so I'm going to use that high-speed mosquito type burr to go from that contact point to the cusp tip or the incisal edge. And I'm going to approach that from not only the buccal, but from the lingual as well. And so I don't like round tripping of teeth. I think it increases treatment time on a lot of adults with recession. I don't want to procline the teeth, go through the buccal plate, and then just come back with additional aligners. So I have utilized the high speed at O2. And again, from that contact point, both facial and lingual, we're going to perform that from the contact point up towards the incisal edge, if you will, on both the lingual and buccal surfaces. There are many different other types of IPR and tools. I've just given you what I utilize in my hands. If you've utilized these other things and you're comfortable with it, feel free. IPR is IPR. But again, this is a great case to explain why I use IPR. So on the left, we have a patient who has already had 2 sets of braces. And, oh, by the way, that's not recession from the braces. It's because she had an unusual orthodontic surgical procedure on the mandible to close an anterior open bite. So I'm an orthodontist, and people tell me braces are the most wonderful thing in the world. And I'm going to tell you that we're in a new time. So I correct a ton of relapsed orthodontic cases from fixed appliances with clear aligners. And again, this is, again, case selection. But in this particular case, the patient wanted me to put on her 3rd set of braces. And I looked at it and I said, there's no possible way. Because if I put braces on this patient and then I send her off for a month, what's going to happen? I'm going to immediately, the wire is going to broaden the arch, and I'm going to increase her recession. Okay. And I also don't want to do that. How am I going to get rid of that black triangle? That's her main concern. I'm going to have to do IPR and constrict the arch, one of the 3 C's of IPR. Oh, by the way, I also, to close that anterior open bite, need passive extrusion. Again, a different technique that we would talk about during treatment planning. But I'm going to close that open bite by retracting both the maxillary and mandibular teeth. And oh, by the way, I'm also reducing the black triangles, and I'm preventing any kind of increase in recession. Very, very important concepts there. Okay, so let's talk about getting rid of black triangles. Again, I've got the guard, two-handed. I'm not worried about the soft tissues at all. And again, straight line access. Oh, by the way, I'm performing IPR on a brace patient. Okay, so I break the contact. Don't have to go 100% down towards the gingiva. And I parallel the walls between those two teeth. And then, of course, I will finish that maybe with a diamond strip that will show next, or I can immediately go to my composite finishing strips, medium and fine. Okay, so that is the disc. And again, double-sided diamond coated. Here I'm using a single-sided diamond perforated strip. And again, you can see the shim. That helps me. And then the first pull through, again, two-handed, protecting the soft tissue. And that's why I like the single-sided, because I know where the diamond coated portion is. And again, I'm flossing their teeth, basically. Okay, floss with a sandpaper grit. Everybody understands what we're doing. Okay, so again, I'm going to do the distal on that tooth, do the mesial on the other tooth. And this time I can control it. I could even go down further towards the gingival margins down there. Okay. And then again, finishing medium composite strip. And then the finishing strip. There are different sizes to the strips. I use a fairly thin strip. And again, it helps me to be conservative. I would rather do less, and maybe I might have to do additional liners or refinement on these cases, but at least I'm more accurate. And again, I don't want to have any sensitivity issues with my patients, and they don't want that either. Okay, and then the final new concept, again, we're using a mosquito high-speed diamond burr, and I'm going from that contact point that's going to cause some binding when I'm trying to derotate that tooth. I go from the facial and lingual side, and again, always towards the incisal edge. Here's a great example on a rotated canine. Again, from the facial surface all the way to the cusp tip, and then on the lingual side as well. That's a great example there. Again, from the contact point up towards the cusp tip or incisal edge. Again, two-handed. Look at that. Very non-invasive. And that's, again, what patients want. And so we've talked about the two main concepts after you've delivered aligners. And again, there's a lot of different ways to do it. What I will tell you is I typically, if it's a year's worth of treatment, I will deliver aligners. And then at the next visit, whether it's a month or 2 months out, they're just getting used to using their aligners. And then we put attachments on. I might do IPR at that time, but I'm going to floss, and we're going to talk about aligner monitoring. I may not do the IPR that's programmed in. I may do it as needed, and that's what we're going to talk about with in-office visits. So all the heavy lifting's been done. The heaviest lifting was case selection and virtual treatment plan. That is totally different than traditional, where we just slap the braces on, and 2 months later, I'm again doing my diagnosis and treatment planning. I'm moving to the left. I'm moving to the right. Next appointment, I'm doing the same thing. With good virtual treatment planning, why I don't do 4 or 5 refinements is because I spend time ahead of time. I've done a year of treatment planning. It's locked in. Once I place the attachment, it's done some IPR. Essentially, most cases, I could hand them a box of aligners. But we do want to monitor them. The patient wants you to monitor them. And there's even the concept of remote monitoring as well. So what is this monitoring? Monitoring is basically fit and feel. And what we're talking about now is how is the aligner fitting the teeth? and particularly the cusp tips or the incisal edges. So when a person seats their aligner, there's going to be a force that's displacing the teeth to the desired positions. And so there will be pressure for that first 24, 48 hours, and then it subsides. And we still, because we want the stability of that tooth to move, we need to have them wear it 1 week or 14 days, 2 weeks, or whatever it is. And there's varyings on what people believe in the protocols. The bottom line is, if the tray is fitting well, and you had a good virtual treatment plan because you did predictable tooth movement with your clear aligners, you should see all the teeth tracking. But occasionally, maybe you didn't perform the IPR, or maybe the engager became unengaged because you didn't use the proper composite, or the patient's been picking at it. And so once an engager becomes unengaged, then there's binding on the tooth. And the one side effect with clear aligners is you will see those teeth intrude. So in this particular case, maybe the engager isn't totally engaged, and so there's binding, or we didn't do IPR, mesial and distal, to this area, or we could have programmed in very high velocity intrusion of the lower incisors, and we were using that engager as a retentive appliance, and we're not getting that intrusion that we need to do. So, and that's why you need to chairside have your virtual treatment plan here. And so we've talked about fit. And then patients always ask me, for 2 days, it kind of hurts. And then by the 4th day, it doesn't hurt at all. That's the feel. So if it's still uncomfortable, maybe they're not wearing their aligners, the prescribed 20, 22 hours a day. So maybe they need to wear it longer. So these are things that you have to have a discussion with, because if you told them they could just change an aligner per day, we might get there someday, they would do that, right? They're really trying to get through here. Again, even though it's a simultaneous streamlined movement of, say, 0.1 millimeter in that proper direction over 20 stages, one stage it might be 1.5. The next stage it might be 1.25. Next, 0.1. So what I'm saying is the accuracy, yes, virtually it should be streamlined simultaneously, but it's probably not exactly like that in the real world. So again, we got to talk about feel. How does it feel? Oh, it feels completely loose, it's comfortable, and it's fitting. They're just about ready to move on to the next set. This is my setup. Again, all the heavy lifting's been done. I basically just need floss. So I'm going to say, hey, it's programmed in on those lower teeth to do some IPR, but am I just going to start revving the burr? No, I'm going to look and see if the aligner is tracking. That means I may not need to do it. Number one, how are things fitting? And feel, they feel great, okay? And then I check contacts. If I see a contact that is very tight, I'm going to perform one of those 3 types of IPR. So this, again, chairside, you got your laptop, your computer. In the fixed world, patients are like, hey, when do I get these off? And I'm like, well, you just got them last month. We told you it was 2 years. You have 23 more months. I got to do a lot of math. Here, we got to do a little bit of math. Patients on tray 10 of 20, they're like, hey, well, doc, when am I done? Well, you're 10 of 20, you're halfway home. So it's really nice as a communication tool. They can see the progress. Really, really nice thing to really increase the communication with your patient. Because again, we don't have to do a lot. If they're tracking well, we literally could hand them a box of aligners. Again, we want to talk about the features. Check to see if we're missing any of the attachments. We want to see if they're wearing rubber bands. Oh, did we not place the buttons at that first appointment? In this particular case, there's actual cuts, both in the posterior and the anterior, but maybe we didn't start the rubber bands on tray 1 or tray 5 or whatever it is. And so now it's time to start looking at that. So again, all of these things are done, whether it's attachments, IPR, or monitoring. We always have the digital version up, our treatment plan to increase communication and help guide us, because when you see a lot of these aligner patients, you can't really remember their actual virtual treatment plan. And then again, you can have the analog there as well. And this has led, if you do all the things that we've talked about properly, and again, there have been direct to consumer companies, they don't do attachments, they don't do IPR, but they could just hand someone a box of aligners and maybe do a little remote monitoring. It's still not going to be as successful as the supervised digital dental monitoring, And now, again, if we do those things properly, we can from afar, either with the apps from the company themselves or a third-party vendor that is known for dental monitoring for both clear aligners. And again, we're starting to do remote monitoring for fixed appliances. Oh, we're going to get to on-demand appointments for that or schedule them out a little further than 4 weeks or 8 weeks, because we can monitor if they have any broken brackets. We can talk to them, communicate with them about their hygiene. And that's really what it's about. All the work has been done, but the patients do need that communication. I'm not going to say it's big brother, but it's kind of important. Hey, you should be on aligner 10. It looks like you're only on aligner 2. What's going on? Maybe you need to come into the office to talk about it. Again, if you do all of those things that we've just talked about, it should be fairly streamlined, and you could have a very nice day at the office and then go about and do the things that you really want to do. So I'll go ahead and go into the chat box and questions. Am I using OrthoFX? Yes, absolutely. I'm not going to go into the history of OrthoFX, but again, I've been teaching in our general practice residency. I hate to say it, but I've been teaching there for over 30 years. We're probably one of the only residency programs that certifies and instructs our residents on 3 different kinds of aligners. And so obviously Invisalign, the very first aligner, is there. I also use Straumann ClearCorrect aligners, and I also use OrthoFX. So our residents are certified in all 3 of those. Because I've been teaching all of those, we have several other companies that want to get into the residency, but it's quite a handful. Practice. In my office, we do utilize all 3 for different reasons, but primarily I wanted to be able to compare them, but also to teach utilizing them. They all have different bells and whistles. OrthoFX, I mean, the representative's going to talk to you a little bit more and more, but there are some really good things, and you really want to know about the history of the company. It is based upon, as most orthodontic or most clear aligner companies, back to the days of Align technology. So the founders and so forth. So it's a really forward-thinking company as far as clear aligners. OrthoFX was saying maybe letting patients wear 8 to 9 hours per day because of their new material. I'm going to let Mariah talk about that. I think that's wonderful, but it is an FDA approved material. And so let's give a little shout out to Lock Fam, who is the person who invented the first clear aligner back in 1999. So, if anybody can really advance the material, that's a huge part of clear aligners, is the actual material. And I'm going to say that in my 25 years, the #1 guy I would go to for material information would be Lock Fam, who is with OrthoFX. How many revisions of the digital treatment plan do you consider before starting? Excellent question. I hope someday that we're going to get it down to the point where it is just 1 or 2. There are things called doctor preferences. And if the treatment planners for the particular company can really dial in your preferences, then you don't have to do too many. But what I will tell you, because I get called in on treatments and trouble and everything, the average doctor, which is sad, just pushes the button. Okay. So again, the problem with that is what's the difference between that and direct to consumer? So we're letting the AI treat the patient, which the AI has improved in the last 10 years. It's tremendous difference. But we really know how to move teeth with clear aligners. It's totally different. Again, pushing teeth versus pulling teeth. There's limited ranges of predictability. Orthodontists are able to get beyond that using some fixed appliances, some auxiliaries. Those buttons for elastics were one of the first auxiliaries that we started utilizing. So what I will tell you is that if the treatment planning team, wherever that is, company, follows my protocols, I'd say it's pretty close after like 2 or 3 versions. And it just depends on the difficulty of the case. So for example, the easiest cases are mild generalized spacing. That should be done within 1 or 2 versions. And it's almost to the point that that's probably the easiest case for AI to solve. My next portion of my orthodontic life, hopefully, is to work with people like LockBAM and other virtual treatment planning so that we can help everyone to have the same treatment plans or similar treatment plans per type of malocclusion. Okay. If there's trouble rotating one tooth that has an attachment and the contacts are light and minimal IPR is needed, what are your top 3 reasons why this tooth would not be rotating? Well, number 1, I do use engagers or attachments, again, for rotations. Now, rotations, there's a couple things about rotations, especially on cylindrical teeth, such as mandibular bicuspids. So we sometimes call the hinge effect, where if you can move, for example, very little rotation on the distal, and that's the center of rotation, and you can move the mesial in or out, that is a more predictable movement. That's number 1. Number 2, if it is greater than 40 degrees, particularly on a cylindrical tooth, you're going to have trouble. I typically will put buttons on 2 or 3 teeth, and using some C-chain, reduce that rotation. I've had 90-degree rotations that I can reduce almost to, say, 20 degrees in 3 months of just using buttons and some rubber bands, if you will. And then from there, now I'm down to 20 degrees, and my aligners can easily do that, say, in 20 stages or 10 months of treatment. So if the contacts are light, that's the first thing. It's the attachment design I would look at. It's the severity of the rotation that I'm looking at. And then again, is the patient really complying? Is it fitting, or is that tooth starting to intrude? Because then there's something that's going awry. So hopefully that helps you. But again, it's typically that the contacts are not light. There's typically some binding or the attachment was not designed properly, why you're having so much trouble. But again, if it's greater than 40 degrees, you're not going to be able to rotate that tooth in, say, 10 stages, because that's 4 degrees per stage. That's way too high of a velocity for that type of movement. The 2 most difficult movements, again, rotation and extrusions. Let me see if I missed any questions. iTero and 3-state shape scanners, are they both in your residency? They actually take records in my office, and I have multiple scanners. Right now, I still just have the iTero scanners, but the scanners are changing rapidly. I do like companies that typically will accept scans from any scanner. As a general dentist, you want to pick a scanner that you can utilize both for restorative and for clear aligners. But I'm a huge proponent of scanning. If you're going to do more than 2 or 3 cases a month, it's almost silly that you're still taking PBS impressions. So hopefully I addressed that. And I think, we have a new one. How to prevent posterior open bite at the end of treatment. That's a very long, that's a very, very common issue. Usually we only see that if the staging is more than 10 months. It's been very, very common. Here's what I will tell you. When I get called on treatments in trouble, I often look at the tooth movements table and I see what was programmed in. If you have a very good posterior occlusion, it's one of the most important things. I use those posterior teeth as anchors. I do not move those teeth. And so I rarely see this posterior open bite, unless it depends on the patient. If they're square jaw and they've got a lot of vertical pressures in the posterior, over 10 months, we started seeing this a lot. We would see a slight posterior open bite. That's also why you don't want to just hand them a box of 10 aligners and say, hey, come on back. The other thing is that typically we are moving anterior teeth. In relapse cases, adult treatment, their bites are typically good. And so you will have interferences because not 100% of the movement will occur. So for example, if I have two incisors, a lower incisor and upper incisor, and they start and they're touching, but I'm proclining both those teeth, but the upper tooth didn't procline as much as the lower, or I didn't open the bite, intrude those teeth enough, you're going to get anterior interference. I could simply equilibrate that case if it's mild. Posterior bite will settle. I can also cut the trays distal to the canines. And it typically, if I find it early enough, will settle as well. But it involves the treatment planning, the length of treatment time, what movements were programmed in. Typically, I see it a lot with anterior movements. And then I typically also see it with 14 attachments on 14 maxillary teeth, because the only side effect on clear aligners is you will see teeth that are binding, they intrude. That's the only thing. If you ever see a tooth that extrudes through a clear aligner, please get a hold of me at info@drlowortho.com. I will fly out to take photos of that, okay? Because I've never seen that in 25 years. The only thing that happens, side effect, is you see these teeth intrude, and that's what causes this posterior open bite. It's either slight intrusion that may have not been programmed in, too much binding of the engagers, and or the movement that occurred in the anterior where now you have anterior interferences. That's typically, are you able to use OrthoFX with iTero scanner? Absolutely. Okay, so most companies will accept those scans. That's one of the problems with iTero is owned by Align Technology. So they really, only accept those scans. So, you got to decide what you want to do. But again, companies that are forward thinking are accepting scans from any scanners. There's multiple scanners out there. The only thing I'm also going to say about a scanner is that I really do like the iTero's outcome simulator. I'm a huge proponent when companies call me as a key opinion leader. We really need to get to the point, because it's probably the #1 change in my treatment consultations, is that every patient who starts treatment, braces or clear aligners, gets an outcome sim, which almost real time shows them my projected treatment plan. The best methods for fixed retainer placement, or is printed removable retainers considered best unless compliance is in question? 2024, 90% of clear aligner people are going to want clear aligner retention. And again, mobile society, post-COVID especially, if you are treating a patient I'm in California, but the patient lives in Florida, I tell them that, it's not a permanent retainer. I loved how you said fixed retainer. It is just like having braces on, okay? But over time, over 1 year, 2 years, 3 years more, what's going to happen when that retainer breaks and they can't come into the office, and now we're going to have relapse? So even if I do a fixed retainer, typically only on the lower from 22 to 27, I will still give them an overlay clear aligner so that if something happens, they have time. But, personally, from a hygiene standpoint, that fixed retainer, it actually does hold the teeth fairly well in most cases. But over time, hygiene is not good. If you can ask any dental hygienist, #1. And #2, there are other issues, including partially breaking down or whatever it is. I like to have the patient have some responsibility. I don't want to say it guarantees back and see me in 5 to 10 years, because now in the digital age, that scan that we took for their retainer is valid typically for 5 years. And so they can be anywhere in the world and we can ship them a retainer. So I love the advantages of removable. I fixed their teeth with this removable concept. And so I'd like the removable retainer concept as well. They only have to wear it realistically a couple times a week at night. Teeth do not move that fast if they were moved properly. But what ends up happening is they forget. And so 3, 4, 5 months whether it's a Hawley retainer, or a removable clear retainer, they forget. So I lean heavily towards that. Occasionally I will do a fix, but they kind of have to twist my arm. And, I tell them, look, I'm only responsible for a certain amount of months from this. And then, I don't know what you're eating. I don't know what you're doing. So we have that conversation as well. Again, if you think about technology, the reason we did fixed retainers was we didn't have the acrylic technology. We didn't have the removable technology. We didn't have computers. So basically, it was just like taking braces on the labial surface and putting them on the lingual. Whether you bond every tooth, that's one technique. But we used it long time ago. We're talking about the early 80s, late 70s, early 80s. We were still fitting bands on the canines using zinc phosphate cement. And basically, they walked around with the most unaesthetic appliance I've ever seen. And again, if you've ever removed any of those, that's an absolute dental nightmare. So I'm really, this is a digital age. It's the highest tech appliance that we're using to fix their teeth. Why can't we just hold it? Again, the only problem is we're not as religious. I don't mean going to church, but if they do something once a week, bowling night, whatever it is, a Wednesday night, if they just wore their retainer every Wednesday night, the teeth aren't going to move. They're just not going to move if the case was treated properly. All right. Any other questions? Some of those were great questions. So I hope I gave, I do a whole 20, 30 minutes on posterior open bites. So that's a very common thing that people see. But again, it starts with the virtual treatment plan. And I don't want to say that I'm a simpleton, but I believe that we need to simplify these treatment plans. If we rely on AI too much, AI has never seen these posterior open bites. And what you'll see is none of these cases that I've looked at programmed in posterior open bites. And so again, we need to educate people. Again, difference between the virtual world and the real world. And so I really spend most of my time removing attachments, removing unnecessary, unwanted movements, and then understanding the design and placement of my attachments. I tell my residents, if you don't know why you're putting an attachment on that particular tooth, get rid of the attachment. Okay, so how frequent should the retainer be remade? It depends on the person. There's so many different retainer protocols now. So there's now some where they can get 2 free ones during a year. And different companies have different protocols. I believe OrthoFX has a protocol, a retention protocol as well. And so that's kind of a nice thing. And that's a huge new thing called Retainers for Life.